Yes, yes.
Dr. Chandrima Pal will be talking on the disc evaluation, disc and retinal nerve fiber evaluation. Dr. Pal is the director of the BBI Foundation in Bengal. She is the president of the Kolkata Association of Ophthalmologists. She is the general secretary of the Glaucoma Society of India. Dr. Pal, very happy to have you here. Could you give your talk?
Thank you, Dr. Shukona. Thank you very much for giving me this opportunity of being a part of your prestigious IC. So I shall take you through disc evaluation, the key signs to look for. The host has, okay. So high intraocular pressure is not primary open-angle glaucoma. The OATS study showed us that without optic disc assessment, you may be missing up to 55% of glaucoma patients. And disc change precedes visual field loss in most cases. Overestimation of glaucoma may happen with large-sized discs, congenital anomalies like coloboma and hyperplasia, and peripapillary atrophy. So any deviation from the customary needs a follow-up. So optic disc changes in glaucoma, you can see a host of points which I have out here, starting from loss of the isn't pattern to localized notch in the rim, acquired disc hemorrhage, wedge diffuse, loss of RNFL layer, absent rim inferiorly, and so on and so forth. So this is how we used to document the disc, say about 20 years back, when we didn't have stereoscopic photography. We would look at the disc at the slit lamp with a high lens, and then we would actually draw it. But today we have the stereoscopic photography, which gives you a much better definition of the disc. So the 5 R's for assessment of optic disc in glaucoma: observe the scleral ring to identify the limits of the optic disc and its size, identify the size of the rim, examine the retinal nerve fiber layer, examine the region of peripapillary atrophy, and look for retinal and optic disc hemorrhages. So the optic disc size is of paramount importance for us to evaluate the optic disc. So you first have to define the scleral ring. Once you define the scleral ring, you have to look for the vertical disc diameter and the horizontal disc diameter. So measurement of optic disc size with biomicroscopy, as I told you, you use a high plus lens and then apply the manufacturer's constant to it, and that's how you get the size. So average vertical disc diameter is about 1.8 millimeters and average horizontal diameter is about 1.7 millimeters. So size of the cup varies with size of the disc. Large discs have large cups, and those could be healthy eyes. That's an average disc with 1.9. That's a small disc with 1.4, and that's a large disc with 2.4. So identify small discs and large optic discs. Small discs, average vertical diameter is less than 1.5 millimeter, and large discs, average vertical diameter is more than 2.2 millimeters. So you could very often find a large disc which you've labeled as glaucomatous and a small disc which we've labeled as non-glaucomatous. So intrapapillary equivalent of the RNFL. So don't confound it with Welschnick's peripapillary scleral ring. So I'm just coming to it in a moment. What we're interested out here is the neuroretinal rim. I always compare it with the donut. We're not interested in the hole. We're interested in the chocolate on the rim. So this is the area which you need to look very carefully, the configuration and the pallor. So neuroretinal rim, what applies is the isn't rule. Isn't rule is nothing, but the largest diameter is of the inferior part of the disc, followed by the superior, then nasal, and then inferior. And any deviation from that actually needs a follow-up. So the neuroretinal rim, the shape, size, and pallor, and then whether the isn't rule is absent or present. So peripapillary atrophy. Peripapillary atrophy, again, what we're interested in is the beta zone. This is the zone we're interested in. We are not bothered about the alpha zone. So if there is a beta zone, that's pathognomonic of glaucoma. So optic disc hemorrhages, detection of disc hemorrhages requires careful optic disc examination. As you see in these pictures, the optic disc hemorrhages that are there. And localized thinning or notch is also a pathognomonic feature. There's a notch out there inferiorly, and that's pathognomonic. About the RNFL, look for silver striations to define the RNFL. You have it diffuse and localized RNFLs, and it also can be graded in normal, mild, moderate, and severe. So to delineate a disc with a cup disc ratio, this is how we assess it. So you put this hole as a 1, calculate this distance, the inferior rim. So in this case is 0.20, and the superior rim in this case is 0.15. So if you add these two, 0.25 plus 0.15, and minus it from 1, you get a disc of 0.65. So cup disc in discs with normal configuration, I just told you that they are generally vertically oval, and localized nerve fiber notching or focal extension, acquired pit of the optic nerve, diffuse rim loss. You've got to distinguish it from all these features. Asymmetry of the cup is another sign which you have to look for, but also be careful of the differential diagnosis like hypoplasia, morning glory syndrome, coloboma, and congenital pit. So asymmetry of the cup size, generally more than 0.2, is common in the glaucomatous population, and entertain strong suspicion if you do see that. So nasalization of the vessels, that is also another sign that you need to when you're doing disc evaluation. And areas where there is thin or absent the neuroretinal rim, that needs to be looked for. This is a picture I got from the forum where you can actually view in conjunction together the visual fields, the OCT, and the optic discs, and actually you can correlate all three and come to your diagnosis. Is rather useful in clinical practice. And this is the Heidelberg. I particularly got this picture because the Heidelberg actually gives you a very good measurement of the RNFL, since it covers the RNFL change due to age. So you can actually see whether it's due to age, the RNFL thinning, or actually it's due to glaucoma. And of course, it does have these quadrant values which it gives. So there's the macular ganglion cell mapping as well, the GCC, the ganglion cell complex, which can be recorded. So the errors that we commonly make are that underestimate glaucoma, not delineating the scleral rim correctly, ignoring the small size of the disc, missing a rim notch, missing a hemorrhage, missing a RNFL defect. This is an example. That's the disc that I saw, and 9 years later, this is what I saw. So if you look at that, this again is actually from the octopus perimeter, and I got this for you because I thought it's a wonderful correlation of structure and function, where you have the structure and the function together. These lines that you see are of progression. So if you compare this with this 1998 with 2007, look at the progression that can be detected out here in the cluster analysis of the octopus. This is another patient 7 years later. And that's the thinning of the retinal nerve fiber layer. And there's a large progression out there. So the octopus is detected in here. The green lines that you see are the areas which have improved, and the red lines are the ones where it's deteriorated. So you can actually detect both structure and function deterioration, progression on the octopus polar trend analysis. So in summary, glaucoma is largely undiagnosed, about 90%. Misdiagnosis is common, about 50%. Pay attention to individuals at high risk. Adopt good clinical practices. Optic nerve head evaluation is the key skill, and it's a must learn. Be aware of the pitfalls in diagnosis. Thank you very much for